Hello, I'd like to welcome you to this talk on arrhythmogenic cardiomyopathy. My name is Shane, and I'd like to start off by introducing myself. I work within cardiac rehabilitation as a clinical exercise specialist at Imperial NHS within cardiac rehabilitation. Cardiac rehabilitation is a national program that caters for patients post-cardiac event, and we operate in a multidisciplinary team consisting of various professionals including, but not limited to, consultants, nurses, dietitians, exercise specialists like myself, and psychologists. I'll explain a bit more about this and phase 3 a little bit later on in the presentation. My education experience varies in relation to working with the general population and then moving on to more the clinical population. But more significantly, I'm studying a Master's in Sports Cardiology at St. George's University. This is a fascinating and extensive course where we gain a comprehensive range of expertise in sports cardiology, including cardiovascular evaluation, cardiac screening, cardiac rehabilitation, and exercise prescription, and the management of athletes and individuals with heart disease. A range of conditions are covered in this course, such as dilated cardiomyopathy, hypertrophic cardiomyopathy, and in relation to this presentation, arrhythmogenic cardiomyopathy. And through studying these conditions in more detail is what sparked my interest in reaching out to the Cardiomyopathy UK to volunteer my time to educate and inform patients about principles to abide by when it comes to exercising post-diagnosis safely. Before we start talking about exercise, we need to first understand the recommendations in relation to heart health. As a clinical exercise specialist, when we see patients in clinic, we need to look at these 4 areas, which are physical activity, exercise, sedentary behavior, and flexibility, mobility. The reasons for this is because each individual that comes into the program is different in relation to their initiating diagnosis, their current activity levels, as well as any limitations they may have. Therefore, we need to have an open and honest conversation with the patient in order to truly provide an individualized exercise prescription going forward to improve this patient's heart health. So let's look at these areas in more detail. Physical activity, as you can see here in this slide, is basically any bodily movement such as day-to-day activities, which might be just walking around the kitchen preparing some items of food, or even when you wake up in the morning to brush your teeth. Therefore, any activity while on your feet and moving around is classed as physical activity. The level of intensity a patient may report, an individual may report, will vary from patient to patient. And this will really depend on their current level of fitness and any other limitations they may have. So for example, walking from one side of the room to the other for one patient might be classed as extremely light or very light, while another patient could consider this as hard or somewhat hard because of the shortness of breath. So for that patient, it might be actually classed as exercise, which we'll discuss in a moment. For exercise, this is a level of activity that is carried out to sustain or improve health and fitness. Examples, as you can see here, might be walking, swimming, or exercise classes. The level of intensity, once again, as discussed earlier, can vary from person to person, but generally this is a level of moderate intensity where your breathing has increased but you're not out of breath and you can still hold a conversation. So for one person, as mentioned earlier, this could be walking from one side of the room to the other, or for another person it could be outside doing a brisk walk. For sedentary, this is a time when individuals are exercising. As we were mentioning, they may go out for a walk and hit a certain level of intensity, but when they finish and they're at home, we try to educate patients about reducing the amount of time spent sitting. So therefore, if you're sitting down at a desk job or just sitting down watching TV, we encourage patients to be getting up mobile every 1 to 2 hours, and this could be as little as 1 to 2 minutes, just to break up that sedentary time. And this has been shown to be very beneficial for patients in improving their cardiac health. Finally, balance and flexibility is another important element in relation to improving an individual's health and fitness going forward. Through improving a patient's balance and flexibility, we hope to help individuals to be more independent in the day-to-day activities, be it showering and even dressing, which can be quite challenging for some patients, as well as reducing the risk of falls. As unfortunately, as we get older, we see a decline in balance and flexibility. So this is a much needed area we need to work on. In relation to these 4 elements here, physical activity, exercise, sedentary, and balance and flexibility, we normally talk about intensity, and this is what this scale relates to. And we use this a lot within cardiac rehabilitation, and it's used a lot within other cardiac rehabilitation programs throughout the country. And if they don't use this scale, they're going to use some variation of this, but essentially this will be the bread and butter of the cardiac rehab. So it's a very important scale. It's called the rate of perceived exertion, and it ranges from 6 to 20, where 6 you're sitting down doing nothing at all, and 20 is the maximum exertion, kind of pushing yourself beyond your limits. So this is in relation to the physical intensity when you're doing the exercise and how hard you're finding it. We mentioned earlier about physical activity, and this can, as I said, vary from person to person, but anywhere from around 7 to 11 is usually classed as physical activity. The exercise elements in relation to moderate intensity is around 11 to 13, equating to a point where your breathing has increased but you're not out of breath, and you can hold a conversation. As discussed earlier, not everyone may be able to attain this level of moderate intensity due to other limiting factors such as hip pain, knee pain, and shortness of breath. So this is where an exercise specialist specializing in cardiac patients will be able to advise for these concerns and advise on the most appropriate exercise and form of exercise. So when structuring an exercise program, this is another important element, because we have the main warm-up, main phase is the middle component, and the cool-down. The reason for this is to gradually prepare your body for the exercise, as it allows for your heart rate and blood pressure to increase gradually, which ultimately reduces your risk of breathlessness, chest discomfort, and arrhythmias. Guidelines suggest that the warm-up should be 15 minutes in duration, and then for the main part you maintain a certain intensity, i.e. moderate intensity, and then at the end you do a cool-down, which again states should be around 10 minutes, with the benefits of gradually reducing your heart rate and blood pressure, which may help prevent dizziness. So that's why we just don't stop exercising. The warm-up and cool-down, though, to note, are just guidelines and can be adapted for the particular activity that you're engaging in. So for example, such as gardening and swimming, if you look at gardening, we might want to be more specific in relation to maybe doing some light pruning activities prior to maybe engaging in more physical digging or cutting the lawn. This also needs to be adapted for a patient with limited physical ability in relation to a warm-up of 15 minutes. They might find this too exhausting, so we need to adapt and reduce the warm-up, main phase, and cool-down to suit the individuals. And this level of alterations to this structure program is usually discussed with a clinical exercise specialist like myself, or someone working within cardiac rehab, to advise on what is the appropriate structure of programming for you and you're taking into account your cardiac conditions. So these are the areas we talked about. So when we do talk about this can be broken into subcategories which are outlined on the slide. So the current guidelines is 150 minutes of moderate exercise, which can be broken into 30 minutes 5 days a week. So this is the general recommendations for cardiac patients, and I'm not saying it's something that you should do, which we'll discuss later how this needs to be altered for your individual condition. The benefits though of this is for your heart health by improving circulation and helping your heart pump more efficiently. It's also recommended in the orange segment to perform strength training at least twice per week, as it helps increase bone and muscle strength, which enables you to carry out your day-to-day tasks such as lifting shopping bags, improving sit-to-stand abilities, and carrying out DIY activities around the house, to name a few, as well as getting back to maybe certain jobs that have a more physical component to it. Improving balance and flexibility in the green section here is also important, as mentioned earlier, as it helps to reduce your risk of falls, which also making it easier when you get, which also makes it easier as well when you're getting changing clothes, i.e. the ability putting on a shirt, putting on trousers, putting on socks, having the mobility to reach to those areas, or even picking up something from the floor. And the last segment at the bottom is sedentary time. As we mentioned, long periods of being sedentary can have a negative effect on your heart, so if you're spending too much time sitting down, we need to break this up. When reviewing this with patients in clinic, can seem like a lot of activity at the beginning, especially after heart event or new diagnosis. So therefore, during the cardiac exercise specialist appointment, we will discuss these recommendations and the best way to proceed forward. For example, at the beginning, achieving 30 minutes of moderate intensity on 5 days a week, this may need to be broken down into smaller bouts with a small in relation to shorter duration and lower intensity, with the aim of building this up. Same can be said for strength training. Depending on your cardiac event, there may be some restrictions on lifting weights if you've had a sternotomy, bypass, valve replacements, or if you have some sort of device, pacemaker, ICD. So magic pill. So why is it important to exercise? I'm sure you already know the benefits, but we just cover this anyway, just to maybe highlight some elements that you were not aware of. So physical activity, exercise has a host of benefits. Unfortunately, we can't get that with a magic pill, which would give you the benefits as outlined on this slide. There are numerous benefits of exercise, some which are lowering your cholesterol, better regulation of your blood sugar levels, for those of you who are diabetic, reducing your or preventing of such diabetes, reducing levels of inactivity, and even helps you quit smoking. So for example, some triggers of smoking might be stress or anxiety or even boredom, so exercise can replace some of these bad habits. Physical activity exercise can also aid in better maintaining your weight, controlling your blood pressure, and of course to reduce stress levels. Other benefits may improve efficiency in circulation of the blood around your heart as the heart pumps. It can also help improving maintaining good bone health, especially as we get older, about reducing falls. So in relation to moving forward, try to look beyond just going to the gym or just doing exercise. Try to understand why you're exercising and what are you trying to achieve, which we'll discuss a little bit more later, but this will help to fill into that. This is another important factor. This slide discusses the risk factors that may contribute to cardiovascular disease. Risk factors can be broken into two subcategories, first being non-modifiable, such as age, gender, ethnicity, which you can't alter, and the other is modifiable risk factors, which are discussed here. So in relation to your heart health, it's not just about exercise, there's also a host of modifications that an individual can do to reduce the risk going forward. And what's important to note with cardiomyopathy patients, although it may not be a lifestyle disease, i.e. elevated BMI, elevated excess alcohol, smoking, what may have caused your condition, but ultimately when an individual is diagnosed with a cardiomyopathy, up to 55% of them, there is a reduction or are not meeting the exercise recommendations, which we discussed here. So up to 55% are not meeting these exercise recommendations post-diagnosis from a cardiomyopathy event. So, and if there's some negative lifestyle behaviors associated with that as well, the cardiomyopathy patient is at risk of developing cardiovascular disease. So we have to be mindful of this as well. In relation to the type of exercise, I get asked this question a lot: which is the best form of exercise? I don't believe that there is a best type of exercise, because as a practitioner, if we have in our mind what is the best type of exercise, be it running, swimming, cycling, dancing, or any other form of exercise class, or even lifting weights, I believe we might have a biased opinion in relation to recommending exercise for that patient. We therefore will be missing one of the essential criteria when prescribing exercise for patients, which is individualization. And what this means is that we discuss through what the patient wishes to achieve from an exercise point of view, what is their limitations, what is their medical condition, what is their interest, their dislikes, time constraints in relation to exercise, and then we work as practitioners to devise an appropriate exercise plan for them. It'll be unfair to say or to encourage patients to do a particular type of exercise when the patient may not enjoy that exercise excuse me, or they may not have the time or money. If, for example, if we're saying they should join a gym, or commitment saying they should go out for an hour walking every day, and they have certain elements of job that's restricting them, or if they have a family to look after, or they have young kids to look after, we can't just say things to do. We can't just tell them what to do. We have to work with them in devising an exercise plan, which would ultimately then impact on their adherence to that activity as they don't enjoy it. Therefore, I believe the best type of exercise for a patient is one where we achieve patient goals through improving cardiovascular fitness, improving strength, and making sure the patient enjoys that form of activity, as well as achieving their personal goals, and also that being safe for the patient and their heart. This is another important topic which has come up in recent times, and gets a lot of debate as well. And I'm sure you may have heard the 10,000 steps being mentioned. So let's understand a bit more about steps, which ultimately accumulates from the moment you wake up to the moment you go to sleep. So activities including brushing your teeth, preparing breakfast, walking around the house, out walking to meet friends, basically any activity that involves any element of walking constitutes as steps. The accumulation of 10,000 steps is not always something we recommend to patients, and thinking that you need to achieve 10,000 steps to have health benefits is not correct. And we'll discuss this a bit further here and in the following slides. So the first study here shows that women who increased their steps to 9,700 per day were able to reduce their systolic blood pressure and body mass after 24 weeks of walking. And the important word here is increased. So they went from a baseline up to this number. So once again, this time talking about 7,000 steps here. The second study is interesting though. This is where I tend to focus on with my patients, as it doesn't really focus the total number of steps, i.e. achieving 10,000. It focuses more on you increasing from your baseline. And we can see individuals who increase their step count by 2,000 per day improve their lipid profiles, i.e. their cholesterol. So focusing on the word increased as opposed to achieving 10,000 steps, this slide is important as it discusses, and it's a recent publication this year from the European Society of Cardiology. And we're focusing on the word increased. And this study here showed that this is significant as well, because it showed where participants had a baseline walking, so whatever it may be, and if they increased their steps by 1,000, they had a 15% reduction in all-cause mortality. And even those who increased from their baseline, be it whatever number that is, it doesn't have to be 10,000, it could be 2,000, 3,000, whatever it is, increased their steps by 500 steps per day, had a 7% reduction in cardiovascular mortality. So it's important to note there that we need to achieve it's important to note here that it's not that we need to achieve a certain number of steps, i.e. a high number, but it's more important about increasing from your baseline. So it can have a beneficial effect. For example, if you're doing 3,000 steps and you increase it to 4,000 steps, or doing 4,000 steps and increase it to 5,000 steps, that will have beneficial effects. And the main point to notice here as well with this discussion is that there was no mention of intensity. It's all about volume. So that means you can be slow walking at your own pace around the house or whatever it is, and it's all contributing to positive health. This slide is continuing with that same paper, and on the top left on here on the diagram we can show that those who achieve the least number of steps, which is 0, have the highest mortality risk, and those who increasing their step counts even to around 2,000, 3,000, that mortality risk starts to drop, and it's having a very beneficial effect. So it's going on to later that 10 might be an optimum number, but if you're totally sedentary and doing no steps, any improvement is going to have a beneficial effect. So try not to focus on 10,000. Maybe discussing with your practitioner, which we'll discuss about later, asking them, is it safe, or can you just work on increasing the amount of steps you're doing at the moment? And I hope this highlights about a little bit more clarity in relation to where steps comes from, and ultimately gets you thinking more about it. So maybe not always focusing on intensity and trying to get the heart rate up. So I thought this would be an important slide to discuss as well. So this is a case study of a patient that was referred to me from a sports cardiologist, and this was a young male of 27 years old who was very fit and healthy prior to symptoms being discovered. So this individual his activities included cycling, running and surfing, and one day he was out cycling and began experiencing breathlessness, which was, given his level of activity, was unusual for this. Therefore he underwent further investigations, and subsequently a diagnosis of arrhythmogenic cardiomyopathy was diagnosed. So when this referral was made towards me, I was devising an exercise prescription for this patient in light of his condition of arrhythmogenic cardiomyopathy and in light of restrictions of 110 beats per minute. So he was advised that by the cardiologist not to go above that. So any patients I work with in cardiac rehab or privately, we need to rethink the sessions. So as a clinical exercise specialist, I need to first understand or ask certain questions, and these are highlighted here. First, what is the cardiologist recommending? Is he referring to an avoidance of certain activities? Is he referring to restrictions of certain durations of exercise? Is it more intensities? Is he advising away from certain sports? And why are they advising away from these? Is there concerns over progression of the condition, worsening of symptoms, which is something I have to closely monitor when exercising the patients to determine if my exercise prescription is suitable or not? So this usually involves a conversation with the cardiologist and also reviewing the patient's medical notes in detail in relation to investigations, treatments, medications, any future plans for interventions, and how will this patient be monitored going forward. Taking all this into account, then ultimately the patient's own interests will be taken into consideration as well before I design any sort of exercise prescription going forward. So in relation to arrhythmogenic cardiomyopathy, we talked about previously the European Society of Cardiology about publishing around steps, but European Society of Cardiology has also have lots of guidelines on cardiac conditions. And for example, here, arrhythmogenic cardiomyopathy, what are the guidelines in relation to exercise? So this is important that when devising an exercise plan, as a clinical exercise specialist or someone with specialist knowledge, to understand and interpret these recommendations in order to prescribe an appropriate exercise program for our patients. It's important to note as well that although for ACM the exercise restrictions are limited, because we can see here it says participation of 150 minutes of low intensity exercise per week should be considered, which is 30 minutes per day. It may not be applicable for all patients, and this may be due to previous cardiac history, unexplained syncope, cardiac abnormalities, to name a few. So once again, it's important that the clinical specialist who's prescribing the program has a close relationship with the cardiologist in order to safely advise on the next steps for exercise. The more and more I work with cardiomyopathy patients and cardiac patients in general, I do see psychological elements becoming more and more significant, and I'm having to address this, I find, more with patients. Because ultimately, for patients in particular with cardiomyopathy, such as dilated cardiomyopathy, hypertrophic cardiomyopathy, or arrhythmogenic cardiomyopathy, the reason this could be a barrier is because when patients are diagnosed, it's not uncommon to see a patient who basically is considered to be healthy, active, and exercising possibly to high level before diagnosis. Therefore, post-diagnosis, when patients are given strict exercise restrictions and told not to do certain levels of activity which they love or they identify by it, this can have, or maybe they've been doing it for the last decade or two, this can have a really challenging for the patient, and it's difficult for them to comprehend that. That's why it's extremely important when working with such patients, and we need to be part of a multidisciplinary team. As mentioned, includes cardiologists, cardiac nurses, dietitians, and important in relation to this is cardiac psychologists. And at Imperial NHS in cardiac rehab, we have been fortunate enough to have access to such cardiac psychologists within our team. Because of my job from an exercise specialist point of view is to advise on safe exercise post-diagnosis, I am unlimited if this patient was an avid runner, cyclist, and if they were told to stop such activity. I'm not in a position to advise against this advice and allow the patient to participate. So once again, this is where the psychologist comes in again, to helping the patient to understand and adjust to their new lifestyle, behavior, or activities. This is why I really encourage patients to think about why they exercise and why it's important for some of the reasons suggested here, which are improved mood, improved self-esteem, improved body image, and is there a way that individuals can still achieve these psychological benefits, but possibly from a different form of activity in relation to reduced intensity, reduced duration, or other forms of activity. If they have a passion for exercise and that is taken away, could we look at different forms of hobbies in relation to painting, pottery, something else they have a passion for, and have made that be their focus. There's no one answer to this for all patients. and it's usually assessed on an individual basis, and the care plan is usually tailored to the person, but ultimately multidisciplinary team approach to this patient can usually help patients adjust to the new lifestyle behaviours following diagnosis. So this is an important discussion as well with this case study. So going back to this, taking into account the previous mentioned points for this patient who was referred to me, I need to think about the patient's diagnosis, the European Society of Cardiology recommendations, medical notes and interests, and the patient's psychological reasons for exercising. And then we look at the exercise guidelines which are stated here, and we need to adjust the exercise guidelines for this particular patient. So in relation to this patient, we were unable to adhere to the top one, which is moderate intensity 150 minutes per week, because we were restricted to 110 beats per minute, which was classed as light intensity. So we had to reduce the exercise intensity. We were able to kind of play around a bit more with strength training, as well bring in some mobility exercises, and also talk about education on minimizing sedentary time. And this is where discussing steps came in a lot as well, because steps for this particular patient was a low level of activity. But once again, whether it's advisable for you to be more focusing on steps and volume is usually a discussion with your clinical exercise specialist, because each condition is different. So what might be advisable for one patient may not work for another one. We also need to provide education to the patient in relation to this RPE scale. We can see number here once again, where 6 is no exertion at all, 13 is moderate intensity, where breathing is increasing, and 15, 16 is quite a hard level. We established through monitoring the patient's heart rate while exercising that the 110 beats per minute equates to around 110 beats per minute equates to 10, 11 on the RPE scale. So when we were exercising, we were constantly asking what the patient was on the intensity, and also monitoring his heart rate through heart rate monitor. We also talked about here, as we mentioned earlier, about the importance of warm up and cool down. So when a patient is not exercising with me, he knew about the appropriate structure. This is the heart rate from the patient during the warm up. So when exercising this particular patient here, as you can see here, is if we did a 15-minute duration. I got the patient to wear a heart rate strap. The reason for this is because we were given restrictions of 110 beats per minute, and I wanted to make sure that we were exercising the patient within safe levels. So you can see here, we had a steadily increase in heart rate. Dropped a little bit at the end, just because we were transitioning into the next phase, but that increases quite safely in the next element. And ultimately, with the warm-up, it should go from a lower level up to the whatever level that may be advised for the patient, as opposed to any sudden increases. In this component, we can see the elements of the main phase, which was done in a mixture of aerobic and strength-based activities, excuse me, based on the patient's goals and limitations. Once again, the purpose of the heart rate here is to determine when we're exercising a patient. If we are prescribing exercise, we need to know the effect that these exercises have on an individual's heart rate. For example, doing an upper body arm exercise such as bicep curls will have a different heart rate response than doing, say, some lower body exercises such as squats, which will vary again if the individual is which will vary again if an individual is running on the spot. So doing bicep curls, doing squats, running on the spot, all have different heart rate responses. Also, the heart responses can vary from patient to patient depending on a number of factors. So what might be a good exercise or a low heart rate response for one patient may not be suitable for another patient. This also provides information in relation to the layout of the exercises. So if a patient is doing a more aerobic based activity such as running on the spot and the heart rate starts to climb, we may follow this with another, and if we follow this with another lower body exercise such as squats, we may see an increase in heart rate above 110 beats per minute. So it's important here as well to alternate exercises. So if the patient is running on the spot, we may alternate this with some gentle bicep curls and marching on the spot, or some other form of strength exercises. So that's why the heart rate strap here in particular was particularly useful, as it allowed the patient to exercise at a safe level while also improving their cardiovascular health. But it's also important to note that we don't just go with heart rate alone. We have to also take into account the patient's RPE, rate of perceived exertion, how hard they're finding the exercise session, how they look in relation to becoming red faced, sweaty, how they are talking, are they struggling for words due to breathlessness, as well as finding, as well as how they're feeling emotionally. And by emotional, I mean, are they nervous about doing the exercise? Because ultimately, this may be the first time that they've exercised since diagnosis. So that's another factor we need to consider when devising an exercise plan. This case study highlighted how even patients with cardiomyopathies who are given strict exercise guidelines can exercise safely as long as there's close collaboration between the clinical exercise specialist and the cardiologist, as well as the wider multidisciplinary team, where possible, as well as having understanding how to design such exercise sessions. This is another element we often see with cardiomyopathy patients and general cardiac patients. And this is just a quick note on pacemakers or ICDs. In relation to these, the devices, they can be present, and this was present in my case study as well. So in relation to my case studies, while I factored this in, he had an ICD. This was not the main limitation. The main limitations was the patient's underlying diagnosis, which is a heart condition. So we were restricted to 110 beats per minute. So that was the main factor, not the patient's ICD. So in relation to yourself, if you do have a device, which would be a pacemaker, ICD, or CRTD, cardio synchronization therapy with pacing /D, which is defibrillation, it's important that you have a conversation with your cardiac physiologist, which is generally the person who you will see on a review basis to check the status of the ICD and going for daily checks. Check with that team, and they will be able to advise on what exercises you should or shouldn't be able to do, any restrictions around arm movements, particularly in the early stages, any activities around swimming in relation to arm movement. So once again, have a discussion with them, and they will be able to provide more detailed advice. So if you yourself have a cardiomyopathy and you haven't been fortunate enough to avail of any exercise opportunities, these are some of the ones we'll discuss now. So phase 3, this is the area I work in, and at Imperial NHS. And in relation to your pathway of care, you can see the phase 1, in relation to phase 1 is when you're in hospital. Phase 2 is when you're discharged home. Phase 3 is the cardiac rehabilitation program, which can vary in length. And an example of the one we run at Imperial is 8 weeks long. You attend once a week for 8 weeks. And all this comprises of a multidisciplinary team meeting of different exercise specialists, such as cardiologists, nurses, dietitians, clinical exercise specialists we mentioned. And I've also mentioned as well, we're fortunate to have a psychologist on our team. If normally with cardiac rehab programs, if they don't have a psychologist on their team, they may refer you out to a program to avail of such therapies. These programs generally cater for individuals of lifestyle-related conditions such as cardiovascular disease, which may require such interventions as bypass, valve surgery, stents, following some type of heart event. We do see cardiomyopathy patients in these programs, but unfortunately, as this is not necessarily a lifestyle-related disease, the referral criteria into search programs in your area may vary, and you will have to review this to see if you'll be accepted or not. And usually, discussing if you have a heart failure nurse, they might be the ones to better advise on if you're eligible for the cardiac rehab or not. And this slide just highlights some of the areas that we look at within cardiac rehab in relation to lifestyle factors, as well as monitoring blood results. So if you want to know local cardiac rehab programs, phase 3, there you can type in this website, although I'm not sure if it's up to date, but it will give you an idea. And generally, you will be referred to a cardiac rehab program once you're discharged from the local hospital, from a hospital. The program you'll be referred to is generally in relation to the program closest to your GP. So the cardiac rehab program, phase 3, that is closest to your GP, not necessarily the hospital where you had treatment. So for example, if you're from Kent and you were visiting in London and you had a cardiac event, you had a treatment in London, you will be referred back to Kent for your cardiac rehab program rather than in London. Separate to this, then, there is phase 4 programs, which is generally a program that you're referred on to after phase 3. So phase 4 is a long-term exercising program for cardiac patients run by appropriate qualified individuals, and this is just generally with other cardiac patients as well. And this is normally discussed in more detail during phase 3, but if you type into this website as highlighted here, you'll be able to find the local phase 4 programs as well. In relation to this, if you would like more information as well, you can always discuss with your GP to determine if you're suitable for these programs as well. Separate to this then is a GP referral scheme. So other exercise opportunities are linked here, for example, with Everyone Active, and it's a 12-week referral scheme that you can get referred into. So you meet up with appropriate qualified individuals, they do an initial assessment, they will devise an exercise prescription based on your limitations, your medical history, and devise an exercise plan, and that will be reviewed again at 6 weeks and again at 12 weeks. And these are some of the conditions that are covered. And as you can see here, the second one from the top left is cardiovascular disease, which may or may not include cardiomyopathy. So it's important to discuss that with your GP to determine if you can avail of that or not. So you can refer into this program through your GP, or you can do a self-referral. So you can just go onto the Everyone Active and type in GP referral scheme. You should be able to find that information. But ultimately, speaking with your GP will get you further information as well. So this slide discusses a list of opportunities in the area where I work in Ealing. So as we discussed earlier in relation to being diagnosed with such cardiomyopathies and in the psychological impact that can have. And we talked about taking up other activities. So it'd be worth looking in your local community. Is there any volunteer groups that you can get involved in? For example, some pottery groups, some gardening groups, some walking groups were allowed to as a different form of activity, which will also have a positive mental health benefit. So this slide here, I feel is an important slide as well, and it's something to take note. And when you have future appointments, it's important to write down questions for those appointments. So we spoke about earlier about the European Society of Cardiology and the recommendations for arrhythmogenic cardiomyopathy patients, and this is a published literature paper from the European Society of Cardiology, and it's what cardiologists and other health professionals go off of. So there's lots of published literature on how we should recommend exercise, treatment plans, medications for our patients. So if your health professional is advising against a certain level of activity, this will usually be based on some form of evidence. So it's important to maybe explore this a little bit more to help understand their thought process. So with this knowledge that you've gained through the presentation today, I want to highlight that it's important to employ this information during next clinical appointment. So when you're speaking with your cardiologist, doctor, nurse, whoever it may be, think of this presentation. So instead of asking questions like, change the format and how you ask questions. So instead of asking them yes, no questions, for example, can I swim with my heart condition, which they may say no, particularly if that person you're asking is a poor swimmer themselves, they might have a biased opinion and deem that as a hard activity, so then they might say no to you. Instead, word the question differently. So say, can I swim with my heart condition? But follow it up with, I swim for 20 minutes, I find the intensity really light, I'm not out of breath, I don't feel any symptoms when doing it, I've been doing this for a particularly long time, and I actually find it easier than walking. So try to give them a bit of background in relation to the activity. Talk about how it makes you feel, how your heart responds, how your symptoms respond, your breathing, dizziness, anything like that. So instead of saying, can I swim, yes or no, or can I do this activity, or can I do that activity, try to give a bit of background and say how you feel to inform that practitioner's awareness and help you to come to a better solution. And if they still say no, that you can't do that activity, ask them what are the reasons they're saying no. Is it because of certain symptoms that you have? Is it because of certain clinical information in relation to your investigations? If so, is it possible to revisit this question again in maybe 6 months or 12 months when you might be undergoing further testing again to see if anything has changed? Also ask for guidelines in relation to, if they say no, what should you do? So for how long should you go walking or whatever it may be? At what intensity? Can you lift weights? If so, how many sets? How many reps? How many days per week should you be training? If they are unable to answer these questions, then you should ask to be referred to an appropriate individual who may be able to provide further information in this area, which you may be referred to individuals like myself, or you may be referred to cardiac rehabilitation, where we advise patients with cardiac conditions on a daily basis in relation to exercise. So this is just some general guidelines which I believe will be applicable for most patients. Although we may encourage you to exercise, there are certain times when we will say to you that you should advise certain levels of activities, and this slide highlights a few examples. For example, we wouldn't advise you exercising after a heavy meal, but you would have to be mindful if you're diabetic, as it's important to maybe have a small snack before exercising to help manage your blood sugars and prevent any hypos. So if some of these symptoms may be obvious in relation to the conditions mentioned here, but for some others it may be not so obvious. So if you have any concerns or any doubts and wondering when you should engage in exercise, it's important to highlight this with a clinician so they can advise on appropriate protocols going forward. This is just a follow-on from the previous slide about things that you should avoid or stop exercising, or maybe seek medical attention, maybe 111 or calling 999. But ultimately, in relation to these conditions as well, once you start exercising, you will get to know your body, and then ultimately when you experience something that seems unusual, i.e. I normally do exercise and this doesn't happen, you will be quickly able to realize whether that symptom requires further attention or not. So in conclusion, the exercise recommendations that we discussed in this presentation is not something I'm advising you, as this was just a guideline to show you the thought process of someone like myself, a clinical exercise specialist, and how we may need to adapt the exercise to suit individual patients. If you do not have access to a clinical exercise specialist like myself, then hopefully you have gained the knowledge from this presentation to challenge your cardiologist in a constructive manner, just to make you more aware of the limitations and why there is limitations, which will better help you adhere to it. And hopefully you can be referred to such individuals in relation to gaining that exercise advice. And if you have any further questions, I'm happy to be contacted on this email, shanepurcellpt@gmail.com. Thank you very much for listening, and I wish you all the best going forward.